Hello, everyone. Thank you for joining us for this part 2 of 3-part webinar series on the topic of setting realistic expectations in the GI suite. Let's talk about the facts of conventional duodenoscope infection rates, culturing, and lab results. Before we get started and get into the content, I do have to read you our disclaimer in full. The comparison to competition has been written to the best of our knowledge at the date of publication. Please keep in mind that our competitors enhance their products as well, so their products may have changed. Make sure you use competitor comparisons only carefully in your conversations with customers. This material does not constitute medical or legal advice and should not be relied upon as such. This material should not be considered as a substitute for carefully reading all applicable labeling, including the instructions for use supplied with the devices and published peer-reviewed articles concerning the topics presented. Before using or selling any product, please thoroughly review the relevant user manuals for instructions, warnings, and cautions. The techniques, instruments, and settings can vary from facility to facility, and it's in the clinician's decision and responsibility to decide in each clinical situation which mode and setting they use. Thank you for bearing with me through that. I will be your moderator once again for tonight's presentation, part 2 of 3 virtual events we are hosting. My name is Melinda Benedict, and I am the current Global Senior Manager of Infection Prevention, and I focus on our gastroenterology and pulmonary products at Olympus America. I am happy to share that we have both of our panelists returning from the first webinar for tonight's presentation, and I'm going to go ahead and introduce them quickly as well. Dr. Michelle Alpha is a clinical microbiologist and world-renowned expert in the science involved in endoscope reprocessing in hospital-acquired infections. With over 30 years of experience and over 150 publications to her name, Dr. Alpha's research has provided invaluable contributions to the understanding of such topics such as biofilm, the importance of monitoring manual cleaning effectiveness, and endoscope culturing. So thank you once again for joining us, Dr. Alpha. And our second panelist tonight, returning again, is Dr. Gregory Cote. Dr. Cote is a gastroenterologist currently practicing at the Medical University of South Carolina, where he focuses on the diagnosis and treatment of acute and chronic pancreatitis, gallstone disease, and other disorders of the extrahepatic biliary tree. Dr. Cote is also the principal investigator for several federally funded clinical trials in pancreatobiliary endoscopy. Welcome, Dr. Cote. All right, so if any of you had joined us last month for our first webinar in this 3-part series, you'll remember that Drs. Alpha and Cote spoke about several topics, including the differences between scope contamination and patient infection, current gaps in knowledge surrounding duodenoscope-related infections, and patient safety issues to be considered when introducing disposable endoscopes into your practice. Today, we're going to continue to build on these topics that we talked about last time by speaking about debunking the challenges of endoscope reprocessing. So before we begin, I'd like to invite you to ask any questions that you may have on the content being presented by typing them into the chat box, which you should see on your screen now. We will get to as many questions as we can at the end of the presentation. If you could also please mute your lines, unless you are me or one of the panelists, that would be much appreciated. Thank you. All right, so to start off, for those of you who have ever reprocessed a flexible endoscope or are even just familiar with the process, you will recognize these steps that I have up on the screen right now. These steps represent the entire endoscope reprocessing journey, broken down really into 7 major topics, including pre-cleaning, which occurs at the bedside immediately after the endoscopic procedure, leak testing, which is an important repair reduction step, manual cleaning, where bioburden is removed to allow subsequent steps in the process to be effective, visual inspection, when the endoscope is looked over to ensure there is no visible damage, high-level disinfection or sterilization to kill any organisms that may remain on the scope after the cleaning process has been completed, and finally, storage to ensure that a reprocessed endoscope is kept clean and out of harm's way before the next clinical use. Documentation, as we all know, is also an important step in the overall process. So now that we've had that refresher course, let's talk to our panelists. Our first question for discussion tonight is, how vital is bedside cleaning or pre-cleaning? And what potential impact exists if this step is missed or not completed effectively? And I think for this question, we'll start with Dr. Alpha.
Thanks, Mindy. In terms of the bedside pre-clean, one statement I would make is that it is absolutely critical. And this was reflected in the recent 2020 review that came out from Maria and Mathuzami from UCLA, where they indicated that the step is absolutely crucial. It's the best opportunity to remove organic material and to reduce the microbial load on and in the endoscope before it gets a chance to adhere or dry onto the surface. And the impact on this, if it's not done properly or not done at all, it basically makes the manual cleaning step much more difficult and increases the risk that the manual cleaning may not be done adequately. And that has downstream implications in terms of the ability of organisms to survive the high-level disinfection. And if we can go to the next slide, I wanted to put together a little bit of data. So it's not just me talking about publications that are out there. These are two older studies that were done in my research laboratory. And although they're older studies and it involved endoscopes that would have had non-sealed elevator guide wire channels, the reality is these samples were taken from the instrument channel, and they very clearly show the impact of the bedside pre-clean. So if you look at the first row, after patient use, before the bedside clean, we actually took samples from the instrument channel and assessed the level of protein and also the level of viable organisms that we could culture from those endoscopes. And we presented it as the amount per square centimeter, which is obviously a very small surface area. These were 10 clinically used endoscopes, so of course, depending on the procedure and the duration, the data will vary somewhat in terms of the amount of material on them. But I'm presenting the data for the colonoscope and duodenoscope. If you look at the protein per microgram per centimeter squared, you'll see that the average from those 10 clinical procedures for colonoscopes was 37 micrograms per centimeter squared, and for duodenoscopes was 11.3. But in both instances, the data to the right in parentheses shows you the range. And the range can go as high as 115 micrograms per centimeter squared. And that's a very high organic load, which does, not surprising actually, because it's been used on a patient and material has been suctioned up that instrument channel. The bacterial load in CFU per centimeter squared, the average for the colonoscopes was 4.9 logs per centimeter squared, and that's a lot of organisms in a very small area. And the range, as you can see, went as high as 7 logs per centimeter squared. And for duodenoscopes, the average was 3.5 and went as high as 5.9. What I'd like to point out is the appreciation of the second row, which is after the bedside pre-clean. In all instances, you're getting over 94% reduction in the protein levels that are there, and you're getting at least a 2 log reduction in the microbial levels. So you can see that it's an ideal opportunity to get rid of most of the contaminating material that's present in an endoscope. And you can see on the bottom row that after the bedside pre-clean and the manual clean done on another set of 10 patient-used endoscopes, you can see that that level of protein goes down even lower and the bacterial levels also are decreased. So this demonstrates how significant the bedside pre-clean is in removing organic material like proteinaceous material and also removing logs of bacteria. So I'm hoping that this data shows that the bedside clean is really crucial and is one of the most important steps in the beginning of the reprocessing of endoscopes.
Great, absolutely. Thank you for that. So building on to that discussion, as I mentioned before, and as Dr. Alpha mentioned, pre-cleaning really should be done in the procedure room immediately after the endoscope is removed from the patient. And so this happens while the patient is still on the table and the physician and the technician and the nurse and whoever is normally in a procedure is still in the room with that patient. So Dr. Cote, this next question is for you from a physician or clinician's point of view. So taking all of that into consideration, what challenges exist with the logistical completion of pre-cleaning at the bedside, and what processes do you think can be put into place to ensure it's done completely every time?
So I'm sorry to say that I represent probably the primary challenge to completing this step well, which is the physician. For the physicians that are on this webinar, they can certainly attest to the issue when you're in a procedure. You're oftentimes needing to switch from one endoscope to a second endoscope, and you're anxious to continue on with your procedure. And that anxiety on the part of the physician can sometimes be exuded into the room and put pressure on the technician or the nurse that's working with you at the table. But we have really drilled down on the importance of this just across our unit, that really, in terms of cleaning the scope, in terms of the magnitude of effect, this is more important than really all of the other steps. And it's a critical component. We talked about this, I think, at the last webinar, which is the analogy of the dish that you fail to rinse off and put in the dishwasher after you eat your spaghetti with red sauce, and you leave it on the table. You let that dried sauce sort of dry on the dish, and then the next morning you put it into the dishwasher and run your dishwasher, and then you realize after the cycle has completed that you still have some spots on the dish, and that's because, again, the due diligence wasn't done up front. So that really holds true. So I think, fortunately, though, there's a natural barrier to maybe the physician's sort of pressure to maybe move the case along, which is that we need that nurse and technician to help us with patient repositioning, loading the next scope. So they are really the principal, involved in this component of the procedure, and they should feel empowered to remind the physician, if they're unaware of, the importance of pre-cleaning. Also, just practically speaking, the device, the equipment boom is typically preventing you from starting to wake up the patient, move them to their stretcher if they're on a different table. So really it comes down to teaching in the endoscopy units the importance of this, empowering the nurses and technicians that they are basically taking over the room at that point when the endoscope has been removed. And this, by the way, is not a duodenoscope specific issue. This is all endoscopes, regardless of its configuration. So really, I think it's education, which is really the purpose of tonight's event, to make sure everyone is aware. This step is important. We also have some sort of soft rules. We don't have a clock or a timer or an alert or anything like that, but we do ask that the pre-cleaning step takes 1 minute minimum for a scope, so that they don't feel like they have to rush. They really can't rush the process of wiping down, flushing all the channels when applicable. So we do have a minimum time standard for this step as well that needs to be adhered to.
Great, I think that's a great point. I think a lot of times we hear about maximum time, but to have a minimum time so that technicians know they have that dedicated time to complete their task is something I haven't heard before, but I love it. So I think that leads really well into our next topic, where we're going to start to talk a little bit about human factors. So let's talk a little bit about that and how they play an important role of endoscope reprocessing. And before we get into the question on the screen, I want to provide a little bit of background to the audience on human factors and what activities Olympus specifically has been doing recently in the area of human factor studies. So Olympus has somewhat recently performed what's called a human factors study, and that was in collaboration with a third-party company that specializes in this type of human factors research. And that study was done to assess the reprocessing of several of our duodenoscope models. And we really wanted to see just how well a representative subset of healthcare professionals can follow an IFU and reprocess a duodenoscope. So what we did is we, alongside of this third party, really looked and evaluated this representative subset that consisted of half nurses and half reprocessing technicians. So these are people that we didn't just pull them off the streets. They do this for their normal day job and agreed to participate in the study with us. So we gave them some duodenoscopes and watched them to see if they could adhere to the reprocessing instructions that were given to them. So some of the facets of the study, as you can imagine, including their adherence to pre-cleaning, manual cleaning, manual high-level disinfection, which we know people don't do a lot of because we like to use AERs, rinsing, and then storage of duodenoscopes. And at the end, when we collected and analyzed the data, something interesting that we found was that most of the mistakes we observed, or the deviations away from the reprocessing instructions, were actually made by only a few of the participants. So in other words, the majority of the participants, both on the nurse and on the technician side, were able to complete duodenoscope reprocessing with little or no deviations from the reprocessing manual, but those few participants made many mistakes. So with that background information, Dr. Alpha, we'll start with you on this one. In your opinion, what processes should be in place in healthcare facilities that reprocess endoscopes to overcome human factors related reprocessing errors?
Well, I think the most basic and probably most important is adequate training, and not just one-time adequate training, but ongoing reviewing to make sure that people maintain their competency. Because I've been in centers where you talk to the staff and you find out that, yeah, they were trained when they first started their job, but there was never any reviews, there was never any monitoring, and there was never an update. And in some instances, not even training when new scopes came in because it was assumed they would know how to do it. So I think really ensuring that there is very thorough and adequate training so that people are competent at what they do, but also evaluating and ensuring they remain competent over many, many years, because it's easy to deviate and start doing things incorrectly. And I think the other thing that Dr. Cote mentioned, and I think this is an important part, is ensuring that the reprocessing personnel know how long it should take to actually do the full reprocessing, because it's not something that you can complete in 3 minutes and get it turned around and, you know, it's back and being used again. And I think it's important that the reprocessing personnel are empowered and know that they should take and are empowered to take the appropriate amount of time to ensure that the full reprocessing, the cleaning, the manual cleaning step, and the AER cycle, et cetera, are all done properly. And then finally, I do think as part of that, in terms of manual cleaning, I do think it's important to periodically at least do some monitoring of the manual cleaning so you can, you know, give feedback to your personnel. Exactly what you mentioned, Mindy. Some people make mistakes and they don't even know they've made them. And I think the idea of doing some monitoring as part of a quality process is really important. And it's not meant to be punitive. It's meant to feed back to the reprocessing staff so that they have an opportunity to correct any mistakes that were made during the manual cleaning. So I do believe that monitoring as part of a quality system approach is an important thing to reduce the problems introduced by human factors. And then finally, I think automation is a very important thing too. You know, using flushing pumps to facilitate the circulation of the detergent and the rinsing liquids, et cetera, rather than people manually trying to flush those and getting carpal tunnel syndrome while they're doing it. I think those are all good things that will help overcome human factors.
Great, thank you. And then passing it over to you, Dr. Cote. Can you just give us some insight on how your facility trains and manages your reprocessing technicians? And do you feel that it's effective and it instills confidence in your staff to be able to do their jobs?
Well, I'm happy with our system. So we have sort of 2 tiers of reprocessing staff. We have staff that are trained in reprocessing standard endoscopes, colonoscopes, gastroscopes. And then we have a subgroup of those that are specifically trained in the devices that have more nooks and crannies, so to speak, like duodenoscopes, linear echo endoscopes, the radial echo endoscope, mostly because of the cost associated with those scopes as much as the processing of it itself. And so it's really a badge of honor to sort of complete an apprenticeship under someone who's been trained and be cleared to have the responsibility of reprocessing some of these higher value, more complex pieces of equipment. But in general, all of our staff that are in the reprocessing suite are aware of the importance. This is something that is brought up at least a couple times a year during weekly staff meetings where they have a dedicated staff meeting talking about, quality control issues that have come up with. Oftentimes it's less cleaning, but as much breaking scopes during the reprocessing itself. So I think those components are very effective. And just like in the room with the pre-cleaning, where the staff are told that regardless of the situation, unless it's life-threatening, they are in charge of the room at that point, and they need to go through the pre-cleaning. Similarly, with the manual clean, they are responsible for basically, completing the necessary steps before it's put into the reprocessing unit for the second phase of the in-room, in the reprocessing room, cleaning and disinfection. So we don't have a formal certification process. We don't have them go through a university. We don't have them go through some of the credentialing that is available out there. I think to your point that you made, Mindy, that's something that we may consider. But I think the culture that I think we've established, no pun intended, and the advantage they have of that Monday through Friday, they are seeing 5 to 10 duodenoscopes, well over 20 colonoscopes and gastroscopes each. So there's such a high volume that that they are not in a situation where they're looking at a device for the first time in 3 weeks and they're trying to remember, what do I need to do with this particular piece of equipment? Counter to that, I think, is the danger of, with high flow is getting lazy and maybe cutting corners. But again, we have sufficient inventory that we're not banging on the door saying, when's that scope going to be ready again so we can use it for the next procedure.
Great. Thank you. All excellent points. Let's move on to the next topic, which I think is a very hot topic right now, and not just for duodenoscopes, but for scopes as a whole, is simethicone. So Dr. Alpha, I want to start with you kind of from the scientific perspective of this topic. In your opinion, what impact does simethicone have on the reprocessing of endoscopes when simethicone is used in procedures?
Yeah, it's a very topical question, that's for sure. I did want to point out, and you've mentioned it, that although simethicone is used more commonly in scopes used on the lower GI procedures, and not as much in the upper ones, simethicone residuals have been found in all types of scopes. So I think it is a germane issue to talk about. I think it's important to recognize that simethicone is actually insoluble in water and it's insoluble in alcohol. And it was introduced and was kind of under the radar for a long period of time. And the purpose of introducing it was that it helps break the bubbles on the surface of the mucosa so that visualization and detection of polyps or abnormalities can actually be more easily seen. So obviously from a clinical perspective, there is a great value in this to improve the detection of abnormalities on the gut mucosa. I think the difficulty was that because it was not recognized as something that was routinely being introduced into endoscopy, you need to recognize that the manufacturer's instructions for use and their validation studies on the cleaning and disinfection of scopes did not take into account the fact that simethicone residuals may be present. And I think that that has been brought to light in many contexts. And I think that the take-home message from this is recognizing that simethicone isn't going to be removed by the current bedside clean. It isn't going to be removed by the manual cleaning, and it isn't going to be removed from processing through an AER and high-level disinfection. And I think that the downside of this is that it does interfere with drying, so that when you actually are using forced air to try to dry the endoscope channels, if there's residuals of simethicone present, it actually does interfere with the efficacy of drying. And the other thing that's been reported in the literature is that from the clinician's perspective, if the concentration is quite high, you can actually get blurring of the image across the lens of the endoscope itself. And so I think it behooves all of us to recognize that this is an issue that hopefully communication between clinical procedures and reprocessing and manufacturing will smooth out, and at some point we'll either have components that provide the same clinical function but don't interfere with cleaning, or we'll get cleaning protocols that will actually be able to accommodate the removal of simethicone. If you go to the next picture, I'd like to point out that in the published literature, Corey-Ofsted studies and also Barakat studies were some of the first to point out the issues around simethicone. And the image that you're seeing now was a study that was done by Barakat in 2018. And what they did, this picture shows flushing of 3% simethicone into the channel, the working channel, and then examining it right after that material had been kind of blown out with air. And you can see in the first panel on the left there, you can see there's pooling of this kind of opaque looking material. And what they found was that even after the manual cleaning, high level disinfection and drying, which is shown in panel B, and also the same one again in panel C, there's still these droplets that remain. And Barakat did a series of other studies and showed that the lower the concentration you use, the less of an issue this is. So the take-home message from all of this, and I think it's the outcome of the published studies, is that there's a clinical value in using simethicone to improve visualization of the mucosal surface, but make sure that it's used at the lowest effective concentration. So about 0.15% is one that it still interferes with drying and it still leaves droplets, but far less than if you're using, up to 3%. So I think that's the take-home message in the published data that's come out there. And I'm hopeful that we'll find either cleaning methods that will remove simethicone or alternatives to simethicone that are as effective from a clinical perspective that also can be removed by the cleaning methodologies.
Great. And I think, Dr. Cote, turning this over to you, the physician's view on simethicone is very strong because there is a clinical value to using it. So can you just give us insight onto how often, in general, simethicone is used by physicians in practice? And do you think, given all of the evidence, both on the reprocessing side and on the clinical side, that the benefits of its use outweigh the risks?
Yeah, I think the scope of this particular issue is relatively small, as compared to the issues around just quality control around reprocessing endoscopes in general. And fortunately, most of the scenarios in which simethicone is needed or preferred are situations that don't involve more complex endoscopes, so linear echoendoscopes and duodenoscopes. It's more commonly something that we'll use during a colonoscopy. So I think that's number one. But on the other side of it is, for example, this was something that never crossed my radar that this would have any issues whatsoever with reprocessing. And so my threshold to request simethicone was extremely low. And so I think, as long as we can educate on the physician side that it's reasonable to use when it's certainly necessary to improve mucosal visualization. But be mindful of the fact that it does add some complexity with the reprocessing. So, you should use it. You shouldn't make it a routine. I mean, there was a time when we routinely added simethicone to the flush for all of our colonoscopies, just because it was nice to have. And that, of course, is not a good idea. First of all, it's just a waste for the majority of cases where you don't need it, but also now this additional factor of this impact on reprocessing. And then I think on the reprocessing side, so in terms of the technicians and the nurses that are in these cases, their responsibility also to be educated on this, particular factor, and to remind the doctor, we're going to dilute this. You should have sort of a standard operating protocol in your unit in terms of how you dilute this. We typically dilute. We only use, I don't know the exact volume of simethicone, but it's very small with a several hundred cc's of sterile water in a basin. So it's fairly dilute, and it really still does the job. So be cognizant of the ability to dilute it and still maintain the effectiveness of the drug in terms of getting rid of the bubbles, basically. And then we also make a point of telling the reprocessing room, the technicians in there, when we bring the scope after the pre-clean, of course, that, hey, we use simethicone in this case, so take an extra look at it, basically. And that, again, I think breaks some of the mundane approach that that one can fall into when you're just seeing scope after scope. We do that for this, as we do it for other situations, such as if the procedure is complicated by a significant amount of bleeding, so there's going to be a lot of blood in the channel. a particularly dirty procedure, will always sort of flag, if you will, that endoscope when we bring it in and say, be mindful of the fact that while we pre-cleaned this one might need a little bit of extra attention during your manual clean phase in the room.
Do you have any opinion on the thought that maybe having patients take oral simethicone as part of a bowel prep, as instead of putting simethicone down the scope? Do you have any experience or opinion on how that works versus doing it in kind of this method with the endoscope itself?
It's just so infrequently needed that it's hard to justify, universal addition of this medication. I'm not sure of its effectiveness as an ingestion in the prep, to be honest with you. I'm not sure if that's been studied. But I think it's not enough of a problem that we need to transform our approach to the bowel prep phase of things.
I'll maybe make a comment on that because you're right, Dr. Cote. There are some publications out there that actually have looked at this, and they found that the bowel prep, as instead of actually putting it in the water bottle at even a lower concentration or higher concentration, the idea of starting the bowel prep the night before and or the morning of, and the data is suggesting that it does actually provide good visualization. So I think there is some data out there to suggest that for those scenarios where it's needed, and it really, the colonoscopies probably are the major one, that is something that there is data on. So if people are interested in pursuing that, they can certainly find some published literature on it in terms of its equivalency to using it during the procedure.
Yeah, I think the split dose approach to bowel preparation has really taken off as by far and away the preferred method. That's without simethicone. I'm not sure about the added value of this, but I think it's a good point.
Yeah.
Great. All right. So moving on to the next topic. So we've gone over pre-cleaning. We've gone over some issues or topics involving manual cleaning with simethicone. Now we're in the next step. We're on disinfection and sterilization here. So let's talk a little bit about this. Dr. Cote, I'm going to start with you for this one. So what do you think about high-level disinfection, and do you think it provides an adequate margin of safety? And to kind of piggyback on that question, do you think a transition from high-level disinfection to sterilization for endoscopes is warranted or not?
So this idea of sterilizing a reusable, flexible endoscope really was increasingly popularized after a few of these case series of these multi-drug resistant outbreaks related to inadequate disinfection of duodenoscopes. And the studies that have been done since on this issue have not shown that the sterilization process itself eliminates any of the things that we just talked about. So that's first and foremost. And there are major negatives to sterilization. So it's going to add significant cost to the whole process of offering these procedures. It reduces the durability of the reusable equipment. And for many units, it may frankly just put them out of business because of the need to increase your scope inventory to allow the time for ETO sterilization to occur. So it may have a marginal benefit on reducing the colonization of endoscopes after high-level disinfection, but it has not been shown to reduce what we're really trying to reduce here, which is infection of future patients or contamination of future patients with organisms from a prior procedure, from a prior patient. So I think this is a non-starter, and it takes the worst factors of a purely disposable system and those of a reusable system and magnifies them. I'm very much against it, I think, at this point. I think if you are well educated and thoughtful and sufficiently staffed, both equipment as well as personnel, to perform high-level disinfection, you can do a very good job of keeping your devices clean and safe for use in patients.
Great. And then Dr. Alpha, do you have anything to add to this kind of very heavy topic?
Yeah, very controversial.
Yes.
I would agree with Dr. Cote. I do think that if it's done properly, you know, the adequacy of bedside pre-clean, the manual clean, and the high-level disinfection does provide an adequate margin of safety. And, you know, further to Dr. Cote's comments, definitely the Narzini study in 2016 actually showed survival of carbapenem-resistant Enterobacteriaceae after ETO sterilization. So the clinical data supports exactly what Dr. Cote was saying in that don't think it's a silver bullet that if you put everything through ETO sterilization that you're going to ensure that everything in that scope is sterile, because you won't. And there's certainly data out there to show that if cleaning is inadequate or if biofilm is allowed to form with wet storage and you get biofilm forming inside the channels, sterilization will fail as well. So there, you know, the concept of sterilization for scopes, maybe for emergency bronchoscopy procedures, you know, you can see the value of that, that there's a role for that in some areas of endoscopy. And ideally, if it were easy to do and had a fast turnaround time, obviously it provides you with a slightly better margin of safety. But if you think about it, the only difference between high-level disinfection and sterilization, high-level disinfection is expected to provide a 6-log reduction in CFU and theoretically should kill any type of microbe other than high levels of spores. And sterilization, on the other hand, also should provide a high, 6-log or more reduction of organisms and should kill high levels of spores. And it basically should kill all potential microorganisms, that could possibly be in the scope. So really the difference is the ability to kill spores between those two methods. And I would agree that if it's done properly and with a quality system approach, that certainly for some of the GI scopes, I think it's still a very valid method of reprocessing scopes.
Great. All right. I know we could probably talk about this for a very long time. I think most of us have. At some point.
But the message though is that the mistake that people make is that, well, we're just going to sterilize our scopes, which will sort of remove our responsibility for these other components, and it just doesn't. It does take away, I suppose, some of the reprocessing that's done on site, or sterilization for whatever reason is readily available. But I just don't see any positives to replacing high-level disinfection with sterilization.
Yeah, I agree with you. There's lots of, I think people have to think all the way down the road, not just knee jerk to think that sterilization is the solution to all the problems, because I would agree with you completely. There's many different levels of things that need to be considered, not the least of which is the logistics. If you're sending it for ETO sterilization, most sites don't have that on site and they have to send it off site. And gosh, don't send a wet scope and transit it for a day and a half, to the ETO sterilization site, because you're going to have bacterial replication. And like I mentioned, if you do get biofilm formation, the sterilization isn't going to work either. So I think, we really need to implement quality systems, and we need to, do it in the proper way. And there should be an adequate margin of safety if all things are done properly, and if there's monitoring to make sure that it is done properly. So totally agree with you, Dr. Cote.
Yeah, and the idea is, well, maybe we'll just transform the whole unit to a disposable platform of scopes to just get rid of all this responsibility. But while we've made this, I think, Michelle, you brought a great deal of science to this. It's not that complicated, at the end of the day, if you're thoughtful. This is not a very complicated thing. It's if you're lazy and you cut corners is when things happen. And that, so to me, to take that approach to justify using, lower quality equipment, much higher environmental waste, I find it very hard to fathom when we're, when again, it's just basically doing a good job at work and being thoughtful really handles this issue very, very effectively.
Yeah.
Right. So we've talked about pre-cleaning, manual cleaning, a little bit about disinfection, sterilization. We're on to drying and storage in our endoscope reprocessing journey. So we've been hearing a lot lately, especially in the last, I would say, 1.5 to 2 years. It's really blown up on the benefits of drying endoscope lumens prior to storage. So Dr. Alpha, I'm going to start with you on this one. What impact does endoscope drying before placing scopes in storage have on contamination? And then also in addition to that, how do you think poor storage conditions can contribute to things like contamination of the scope and biofilm formation?
Okay, so I think it was interesting to to look at this picture because Thaker in 2018 actually did a survey of 249 endoscopy sites, and they found that less than half of the sites were actually using forced air to dry the endoscope channels prior to storage. And what this tells us then is that there is widespread lack of compliance with the guidelines that are out there. In fact, Thaker commented it was shocking to see that so few of the sites were actually using forced air drying. And I think part of the reason why this hasn't been integrated as well as it should have been into the procedure is that there is widespread belief that the automated endoscope reprocessor, the AER cycle, if it has an alcohol flush and forced air dry in the end of the cycle, there was widespread belief that that was adequate to meet the manufacturer's instructions indicating thorough drying before storage. And I think that Corey Ofsted's initial studies and certainly Bearcat's studies as well have clearly shown that there is widespread residual moisture inside endoscope channels that have been through a full AER cycle and have been dried overnight. And I think this awakened certainly myself and I think many others that the issues around drying are not being met by an AER cycle. And if you can go, the image that you're seeing right now, this was a study that was done by Bearcat. And basically what we're looking at is down the instrument channel through the biopsy port. And this was an endoscope that was used on a patient. It was actually fully manual, bedside pre-clean, fully manually cleaned. And then it was reprocessed through an AER and the air flush, the alcohol flush and air flush were done. And you can see the red arrows point out to the residual moisture that is in the channel. So this is a scope that's just come out of an AER, and it shows you how much moisture there actually is in the instrument channel. And I won't bore you with the details, but basically Bearcat did a number of assessments to determine what would be the best way to try to get these scope channels dry. And what they recommended was automated drying, where there was an air flushing pump that could be used, and that it was more effective than having a staff person standing there with a forced air, compressed air gun drying each of the channels for 10 minutes. And so this is, again, automation, I think, facilitates improving the quality process. And the other thing is that there are channel purge storage cabinets or storage cabinets that will flush air through the channel so that you can kind of engineer safety into this process. But I think the awareness came with the boroscope studies that were done by Ofsted and also by Bearcat. And it's pretty clear that if you look at the FDA data, they have indicated that about 5% of high concern organisms are cultured from endoscope channels when they take them right out of the AER and take samples and culture them. So what this means is that in at least 5% of the scopes in the United States, there are organisms still in these channels. And if that's in the presence of moisture, they will definitely be able to replicate during storage and potentially form biofilm. So I think recognizing that it behooves all of us to make sure that the drying is done properly and that this is something to really pay attention to, because you can do everything correctly up to that stage. And if you store the scope with moisture in the channels, you've undone all your good work, because even the environmental organisms, if they get in and replicate and form biofilm, it's going to make it cleaning and disinfection after that very, very difficult. So if you can go to the next slide. There also was a very recent study that was done by Nerzanik, and what they used was a skeleton endoscope model. So on the left, you can see A and B. A just shows you the skeleton endoscope model, which it's a patient use scope that has had all the exterior sheathing taken off, but all the connectors are still there. And they were looking at the efficacy of various drying methods of the various channels in a colonoscope. So I'm going to cut to the chase on this. In A, that's a multi-channel connector that is going to flow air through those channels simultaneously. And in panel B on the left lower, you can see there's a pistol there that is with a compressed tank of air that's medical grade air. And this is the traditional way of taking a person and holding it to each of the orifices and blowing air through the channel. Now, the data on the right, again, you can see if you use method A, which is the all channel one, it takes at least 25 minutes to get all of the channels, the air water channel, the suction instrument, and the auxiliary water, red, blue, and green. And you can see that if you use method B, which is doing each channel independently and standing there for a period of time, it's going to take you a total of 50 minutes. And the channels that take the longest to dry differ depending on the method you use. The bottom line here is that you can't take a 1 or 5 minute air flush of these channels and think that you've actually got them adequately dry. And so one thing to mention in this study, in their Zendic study, didn't compare the air pump or the forced air drying individually. They didn't compare it to a channel purge storage cabinet. And you might ask the question, okay, this is people doing research and science, and does this really translate into the clinical world? Well, Saliu in 2016 actually compared the contamination rate of patient-used scopes, and what they found was that when they used a channel purge storage cabinet, only 9% of their scopes had high concern organisms. If they used a regular storage cabinet with no forced air going through the channels, 32% of their scopes were contaminated with high concern organisms. So it does translate to real life, and it does mean that if you don't have adequate drying, you will have microbial replication and you will get yourself in trouble, potentially with biofilm formation because of that. I'll stop ranting now.
Yeah, no, that was great. So, you know, keeping in mind that the next slide, we're going to talk a little bit more about education and training. But Dr. Cote, Dr. Alpha, just thinking about everything we talked about before we go into that education and training world, you know, where do we go from here? What do you think needs to happen in the industry as far as endoscope reprocessing to further improve upon the quality of endoscope reprocessing? Dr. Cote, do you want to go first?
Well, this issue of drying, just to comment briefly on that, this is, new. Michelle can speak to this, but I think in certain parts of the world, this is mandated or much more strongly emphasized than in others. And to be honest with you, it's not something that we've paid a great deal of attention to at MUSC here in Charleston. But again, this is something that's relatively simple to add to the process. It doesn't require skill; it just requires the right equipment and the knowledge, basically, to implement it. Now, the cost of these, air drying cabinets and so on can be a bit much at this point, but I suspect that if this is something that is increasingly popularized and at some level widespread mandated for all endoscopes, you can imagine the competition will go up in developing this technology and the prices will go down. So I just wanted to comment on that. I think it's something, again, that individual centers should evaluate in addition to all these other steps. In general, I think, and I think Michelle made this point during the first of these webinars, the key, I think, component here is that every unit needs to know what they're doing and how they're doing now. We have been at various times much more hypervigilant than others in terms of evaluating our effectiveness at properly disinfecting these scopes. And it's a continuous process of evaluation, modifying the process, tweaking it here and there. And again, I think the principles that we've talked about tonight, which is taking the time, acknowledging and basically placing on a pedestal those that are in charge of these aspects of the disinfection process, and then just education, making sure that all staff, physicians, nurses, technicians, et cetera, are aware of the issues, and health system, by the way, because they're the ones that ultimately have to buy the equipment, and have to justify your inventory and so on. So I think it comes down to evaluating at your center, your process, making sure it's in line with current standards, which continue to evolve, working with your infection control experts at your center or nearby affiliates to assess your performance, and making a point of really rewarding the personnel that are involved in this process, because it is a skill set. Again, it's not complicated, but it requires someone who is thoughtful and basically anal retentive to, to stay on top of this. It's easy to get lazy and cut corners.
Dr. Alpha, what are your thoughts?
Well, I agree with everything that Dr. Cote has just said, and I think I'll just add the information that you were alluding to, Dr. Cote. Australia has mandated the use of channel purge storage cabinets for duodenoscopes and for other scopes, and in Europe, they basically, that's the preferred recommendation for scope storage. So it's not, it is in other parts of the world something that is more common than it is in North America. From my perspective, in terms of where do we go from here, I do think it's really important that audits are actually done, and it's not to penalize. I love Dr. Cote's approach that, really empower those individuals that are doing it and put them on a pedestal. Part of monitoring, though, is to give them feedback so that they know when there are problems with their process. And it's in my mind, people ask me, and I often recommend, if you want a place to start, there's two places. One is do some monitoring of the manual cleaning and see how your techs are performing, just to give them feedback. And it's a quality systems approach to give. It's empowering the techs to know whether everything is going fine or whether there's need for further improvement. And it's great to use when you're training techs to do the cleaning as well. The other component is monitoring the drying. I do think it's important people look at their endoscopes, and Corey Ofsted and others have indicated that there's paper strips that it's change color when they get wet, like your baby's diapers, and you can actually use that low-tech methodology to flush air through the channel and see whether you get any, or take a swab and put it in the channel and put it on the paper. So there are ways for you to monitor and check to see how good your drying is actually being done, and it helps convince people if they need to make some changes. So I agree. I think it's really paying attention, auditing, monitoring, providing feedback, and a quality system approach.
All right. So coming towards the end here, I'd like to touch on, and again, we have touched on this at points throughout the presentation so far, but really to kind of bring it home as far as the importance of education, training, competency monitoring and things like that. So what this slide kind of outlines for us are, other challenges that maybe reprocessing technicians and facilities have to overcome at some point during endoscope reprocessing to make sure everybody's doing a great job. So we talked about some human factors, but there are things such as high staff turnover in some facilities, compensation. People may not be getting as paid as much as they want. Education and training. There are some centers, or hopefully not, but maybe many centers that don't have a formalized training process for their endoscope reprocessing techs. And also like Dr. Cote does in his facility, which I think is fantastic, kind of have everybody very well trained on your basic scopes, and then that subset of kind of superstars that are trained on the specialty scopes. And then external forces. Dr. Cote, you talked about this a little bit when we were talking about pre-cleaning, but technicians feeling pressured to reduce their turnaround times when they clean scopes, and dealing with increased procedure volume, and maybe also at the same time decreased staffing. So taking kind of this whole slide into consideration, Dr. Cote, we'll start with you again. Do you think these sort of more personnel and work environment related issues are easy to overcome?
A lot of these are really cultural, and so it comes at leadership. It's nurse management, it's physician leadership, and education, so that everyone understands the importance of the offering endoscopy services. Isn't just all about the physician or the facility. It's really it's a group effort, and so if that's the culture that is emphasized, I do think a lot of this is actually very, very easy to implement and to sustain. I'm not sure about the certification process itself, because oftentimes, as I know from having to do licensing and so on for my own credentialing, it gets expensive. But I think if there's a low cost, effective training method, and it gives someone a badge that distinguishes them from others, I think that there's value there.
Dr. Alpha, do you have anything to add?
No, not much. I mean, I've commented already on the idea of looking at monitoring to ensure ongoing competency, and I would agree with all the things that Dr. Cote has said, so I won't repeat.
Yeah, great. All right. So to kind of support that conversation, what I'd like to do real quick before we go into a short Q&A, I realize we're coming up on 8 o'clock Eastern time. I'd like to quickly review some of the educational offerings that Olympus actually provides to customers to support continued learning on the topic of reprocessing and infection control in endoscopy. So really quickly, you know, everybody can read the slide here, but some of the things we do offer is an online resource library where you can find quick reference guides, wall charts, and forms to help you and your staff with the reprocessing of Olympus scopes. We have off-site programs such as Olympus University, which is sort of rebranding into Olympus Professional Education, but we have online courses, and we're continuing to kind of beef up that offering. So whether they're CE granting or not, there are educational offerings available virtually and on demand for customers to access. On-site instructor-led programs, we have a fleet of endoscope support specialists, which if you have a service contract with Olympus, you probably know your ESS, as we call them, that will come through and help you, help your staff reprocess Olympus devices correctly, and also really help reduce damage and repairs to your endoscopes. And then we're also in the process of improving our IFUs. We're trying to simplify them while still maintaining a validated reprocessing instruction base within them, and then supplementing those with instructional videos. Another thing we're doing here, which is really cool and pretty new, is we have what's called our Amplifier learning module. We have this right now just for the TJF Q190V, which is the new disposable cap duodenoscope, and also the previous model, the Q180V duodenoscope. This Amplifier program is actually very cool. It's offered free of charge to all Olympus customers, and it is an interactive quiz-based learning experience that includes a learning continuum and knowledge checks sprinkled throughout the module. And what's really cool about this and sets it apart from just kind of your typical multiple choice Quizlet that you might take for any other kind of CE credit is Amplifier is the company that helped us build this. And what they do is they use cognitive science and they create an algorithm that helps ensure that content not only is answered correctly by the quiz takers, but is actually learned and retained by all of the users. There's a lot of science that goes on behind it, which I won't get into, and I don't even think I could because it gets complicated, but it's really cool. It's not like a normal quiz module. And again, this program's free to Olympus customers. In addition to all of that Olympus offers, you'll see at the bottom there, the CDC icon. Please, if you haven't already, the URL is there. You can also Google it, pops up pretty easily. The CDC offers their quality systems approach resources. So this is very, you can definitely use it in your endoscopy suite to manage your staff and your quality systems processes. They have a lot of templates, guidance tools, and other resources you can use to help kind of oomph up your endoscope reprocessing program should you need or want to. So with that, we have a couple of minutes for a quick Q&A, and as I've been talking, my colleagues have very kindly been texting me what some of our audience members have been typing for questions. So let me just see what we have.
Yeah, I've tried to, while you're looking at that, Mindy, I've been looking at the chat queue here and tried to answer just in the interest of time, some of them, but there have been some great points. But there was a question about this issue of when the scopes are being switched in procedure. And there are scenarios in which we may take an endoscope out, but feel the need to reuse it later during the same procedure. So what do you do? Because obviously if you do the manual bedside clean, and you can't put that back into the patient. So first we try to, as a physician group, we try to minimize that, again, with understanding the awareness and importance of the bedside clean. But there are situations in which it's simply unavoidable. And so, again, barring an emergency where a scope has to be switched out enlightening fast speed to get down to control a bleed or something along those lines. We basically, the nurse or technician will do a bedside clean, but just with water, so that it can still be used. So they still wipe it down, they still flush it out, but they're not using the cleanser at the bedside. And then obviously, after the last use of that endoscope, they will go through the bedside clean again, even if we ended up not using that scope the second time. I think that was one question I wanted to make sure we addressed. The other was a question about what do you do with an expired scope that's on your shelf that's been reprocessed, disinfected, et cetera, but then it expires. And I don't know if Michelle, Michelle, do you want to tackle that question about what's recommended for an expired scope that hasn't been used yet?
Sure. I think the key issues there are that, number one, establish what your storage duration is. So if you look in the literature, anywhere between 5 to 7 days, I think 5 is, in my opinion, probably a safer duration of storage if it's within the 5 days of reprocessing, to reuse it. And the real question is, if it's expired, do you have to clean it in addition, and also do the disinfection again? I think if you're erring, there is no data that I can quote you on this, and there's no right or wrong. But from my personal scientific perspective, I would suggest that if a scope has expired, I think ideally it would be cleaned and high-level disinfected. The whole process, and put it through the same thing, because if it did have any problems during storage and it's been storage beyond its shelf life, I think it would be important to actually do both of those things. Minimally, it should have the high-level disinfection repeated, but in many centers that use AERs that have a cleaning cycle incorporated into their AER and their high-level disinfection, you're going to be doing both of those things. And I would recommend that the AER cycle with cleaning and disinfection be what would be done in a scope that's reached its expiry date.
Great. There were a few more questions, but we have actually exceeded our time today. So again, if anybody had any other questions, feel free at any time to reach out to any of your Olympus representatives. They can hook you up with the answer. If they don't have the answer, they know where to find it. So I'd like to thank our panelists, Dr. Cote, Dr. Alpha. Thank you again for jumping on and discussing these really important topics with us and for our audience. We are lucky enough to have both of them back for part 3 of this webinar series. So please save the date. It's going to be February 10th at the same time. Please pre-register for that so you can come in, and we will be diving a lot more deeply into the actual sampling and culturing of duodenoscopes, including kind of what to do when you get a culture report back from the laboratory and you're faced with deciding how to handle those results. So a deep dive into sampling and culturing to wrap up this 3-part series. So with that, thank you again to our panelists. Thank you for the attendees. Have a fantastic night.